So today we will be discussing a case of a professional golf player. He is 40 years of age and he has been complaining of loss of power in his dominant arm. On examination, there is total loss of external rotation. So there is also loss of the movement of the hand. So that is uplifting his arm, that is lifting his arm above the head, and this is clinically called as drop arm. For that, he has been referred for an MRI where they are suspecting some kind of neurological complaints. So we'll go through this MRI step by step. First, we will start with evaluation of the rotator cuff. So the rotator cuff tendons, this would be the anterior aspect and this would be the posterior aspect. So on the anterior aspect, we have got the subscapularis, which would be inserting onto the lesser tuberosity. So we'll trace it all the way onto its insertion onto the lesser tuberosity. We are seeing that the uh, subscapularis tendon appears intact. No evidence of any tendinosis or tear is seen. Now going on to the supraspinatus. So in the supraspinous fossa, we'll trace from the myotendinous junction all the way up to its insertion onto the greater tuberosity. No tendinosis or tear is evident. The same thing will do for the infraspinatus. Again, from the myotendinous junction, we'll be tracing it up to the level of insertion onto the greater tuberosity posterior aspect. Some kind of hyperintense signals on the PDFS signals images noted within the conjoint fibers. This can be spurious because of the magic angle effect. So we'll just ignore it. It is not anything specific. No tendinosis or tear is evident. The same thing will do for the teres minor muscle. So from the myotendinous junction, we'll trace it all the way up to its insertion. So all the rotator cuff tendons are intact. The second thing that we'll do would be to trace the biceps, long head of biceps tendon. The long head of biceps is sitting in the bicipital groove. No surrounding tenosynovitis is seen, and we are able to trace it all the way onto its insertion onto the biceps labrum. So this is the anchor, biceps anchor is there. So this is the intra-articular course of the biceps tendon. We are tracing it completely up to the anchor. So that is normal. Now we'll go on and evaluate the muscle bellies. So we are seeing that the bulk of the muscle appears normal. However, certain edematous changes is evident. When we adjust the window setting, we are able to see that there is certain edema noted within the supraspinatus, infraspinatus, and the teres minor muscle bellies. In the teres minor, there is some increase in the vascularity. So the vessels within the teres minor muscle belly also appear prominent. Rest of the muscles that we are able to see, this would be the posterior fibers of the deltoid, this the anterior fibers. This would be the subscapularis that we are seeing, the subscapularis muscle, the teres major, the trapezium, all the muscles appear normal. So when we see this appearance, this would be in the region of the denervation edema. So this would be the denervation edema. Now we'll see whether there is any fatty atrophy of the muscles, and on T2 weighted images we are not able to see any fatty atrophy whatsoever. So this is early subacute or acute kind of denervation changes we are not able to see. So now if we want to trace the pathology, we'll again go systematically. After the muscle evaluation, we'll go towards the labrum. So labrum will start from the 12 o'clock position. Anteriorly it would go from 1 to 6, and posteriorly it would be from 7 to 12. So tracing anteriorly, we are seeing that some amount of fluid is there adjacent to the labrum. This would be the anterior aspect of the labrum, and when we correlate with the sagittal images, we see that this labral aspect corresponds to 3 o'clock position. So the fluid started somewhere around 2 o'clock position. So we'll just try and see whether we are able to appreciate this. So this is better seen on the sagittal images. There is some fluid in this region. So this corresponds to a small tear with a tiny paralabral cyst formation that is in the anterior aspect. Now we trace it up to 6 o'clock, it is good. Now we trace it again back at 1 o'clock position, 12 o'clock position. This would be the anchor, biceps anchor, and this seems to be normal. On the sagittal images will correlate with the biceps anchor, so no hyperintensity or any fluid cleft is evident, so superior labrum appears normal. Now we'll investigate the posterior aspect of the labrum. Here we are able to see some fluid in the posterior aspect, which is seen coming up to the posterior labrum. So this corresponds to somewhere around 8 o'clock position. So this would be the large paralabral cyst which is extending posteriorly into the region of the spinoglenoid notch. So this would be the paralabral cyst which is extending. It is coming usually, we should be able to see the type of tear from where it is originating. Sometimes if it is chronic, we won't be able to see the tear because it would have healed, but here we are able to clearly perceive on the sagittal images this fluid cleft in between the chondrolabral junction. So this would be the site of the tear. So we'll trace it superiorly. Somewhere at 9 o'clock position we start to see this tear. It is going all the way up to the 7 o'clock position. Again we are seeing that there is another paralabral cyst which has dissected downwards into the quadrangular space. So this would be the quadrangular space. Again this is nicely depicted on the coronal images. So this sagittal and coronal images, both we are able to see this paralabral cyst better, and we see that there is some connection between the cyst which is extending in the spinoglenoid notch and the cyst which is extending up to the quadrangular spaces. So in both these spaces we will be having the neurovascular bundles which would be traversing from there, and this is a potential site where the nerves get irritated or impinged upon because of the paralabral cyst. And so it's, if we are seeing a type of denervation changes, we need to see what kind of distribution is there. So the pattern of distribution is the involvement of supra and infraspinatus, which gets supplied via the suprascapular nerve which passes through the spinoglenoid notch. So this paralabral cyst would be causing the compression over here, and the teres minor, the denervation that we see, it is supplied via the axillary nerve. So this paralabral cyst which is extending into the quadrangular space may be the causative factor for that. Again on the coronal images we are able to appreciate this hyperintensities on the PDFS images, and the prominence of the vessel that we see in the teres minor muscle is also evident on this images. So now actually usually it's not possible to trace the nerves at all because the nerves won't be that hyper intense, but sometimes in cases of denervation they become bright. So we'll try and trace this. So if we go inferiorly, we would be able to see this tiny nerve which becomes bright in this region. So that would be the axillary nerve. So this would be again the brachial plexus, and another one we are able to see here some bright signal which we are able to see. So this would be corresponding to some other nerve. Usually in this region it would be a long thoracic nerve, and this would be the region of the supraspinous fossa, and the nerve would pass from here and it would go inferiorly and terminate by giving branches to the infraspinatus. So somewhere in this region will be the site for the suprascapular nerve to go. So rest of the things, the bone appears normal, no marrow edema is there, the greater and the lesser tuberosities appear normal, no evident cystic changes or anything is seen. Now we will just end by evaluating the acromioclavicular joint. It also appears normal. The type of acromion is type 2. There is no any spurring or anything is evident. There is subtle edema in this region of the deltoid, maybe a low grade sprain, as this player is a professional golfer, so this can be an expected findings. Again in the coronal images will be in the sagittal images will be able to see the brachial plexus here. So nothing much to be appreciated in this region. So this was a case of acute to subacute denervation which occurred because of a paralabral cyst in an athlete. So this type of cases, when we are able to see this paralabral cyst, large paralabral cyst, it becomes obvious the cause of the denervation. Okay, thank you.